Uh, Dear colleagues, first of all, I want to thank you for invitation to Asia Medical Innovation and Development Forum. I have a strong feeling that together we will make medicine more effective and more safe. That's why I will speak today about patient safety in ICU, challenges and opportunities. My name is Kateryna Bielka, and I'm from Bogomolets National Medical University in Kiev, Ukraine. I declare my conflict of interest, and at first I will speak about patient safety in preoperative period and ICU, why it's so important. About main challenges in ICU, how disaster or war could influence patient safety, and how to improve safety. We will speak about organization, how to improve teamwork in your ICUs, about education, about technologies, and incidents and complications, reporting and analysis. So first of all, I just want to show you some pictures of Kiev, Ukraine. This is lovely city, and of course, you are welcome. But as you know, now we have a difficult situation in our country. Still, we conduct our education and, of course, our medical services. Bogomolets National Medical University had above 13,000 of students, a lot of residents, near 11,000 PhD students, around 3,000 of staff. And first of all, let's talk about why we speak about safety. That's because the human is to make mistakes, yeah. And unfortunately, in high income countries, 1 in 10 patients are harmed by the health system. And as you can see on the slide, medical error is the third cause of death in the United States, and 25% of patients globally experience harm during medical care. And what can we change is that near 50% of this harm is preventable. When we are speaking about ICU, of course, the risk of adverse events more even increase. As different authors said, near from 1 to 2 errors per patient per day happens in general ICU in university hospital. And of course, these events, these errors, increase the ICU and hospital length of stay in patients who suffered this event. And of course, we want to decrease these incidents. The most frequent causes of harm to patients, as WHO say, are medication errors, surgical errors, healthcare-associated infection, diagnostic errors, unsafe transfusion practices, lack of experience in choosing clinical tactics, and incompetence of the personnel. So a lot of things could happen, unfortunately, during critical care in ICU. And how we often say, there are no some one reason. Yeah, usually there is some 2 or 3 or several reasons why this harm to the patient happens. And it could be from the team, from the provider, from technical devices, from some funding and resources, and organization problems also cause this harm to happen. In ICU, of course, all these factors even increase because there is a complexity and intensity of care, high-risk decision-making, time-dependent decisions, adverse drug events, long length of stay, personal fatigue, and so on, so on. Uh, of course, this cause a lot of incidents in the ICU. And how to manage this, how to promote safety for our patient. We can use different methods, like the different walls between the potential adverse events and our patient, using policy, using some standardizing or simplifying, automation, which our technologies do, and improvement to device. And all these methods could help us to achieve the patient safety goals. These are international safety goals for patients all over the world. The goal number one is to avoid mistakes with identification. Number two, improve communication. Three, improve safety of high alert medication. Four, avoid mistakes with procedure, with correct site procedures. Number five, reduce the risk of healthcare associated infection. And number six, reduce the harm of falls of the patient. And when we speak about our ICUs, and especially about our future ICUs, we can speak about a lot of opportunities for us to improve safety. And these are the two new articles about our future ICU and safe ICU design. And if we will speak what are the key points of these articles, they are better organization, better teamwork and using checklists, better education, technical innovation, of course, and including telemedicine, using artificial intelligence support, and expanding ICU care beyond its walls. So this is just a small example how communication could make harm for the patient. This is the case from UCHEN publication in 2022. And this is the case with patient who had low um, low natrium, blood natrium, and different doctors saw this patient and even nurse, and everybody prescribe this hypertonic saline, and then only nephrology consultant and in 2 hours realize that this infusion has nearly finished, but it was too quickly for natrium. So this is how it works in medical system. When there are a lot of people who manage the patient, they could just lose their communication and everything will go wrong. And evidence show that when you improve communication in your team, the risk of infections decrease. And communication is one of root causes, as you can see, 75% of infection-associated events. So what can we do with communication? This is the first option. This is CASP program, which is now quite popular in different ICUs in the world. This is a program from United States, which provide free education resources for your ICU and for your hospital, training resources and tools to help medical personnel to understand the science of safety and to encourage them to use it better. And it's really help. Already we have publication that this program significantly decreased the incidence of ventilator associated pneumonia and also wound infection. So it really works. Another idea is to use checklists in your ICU. This is example from Gary Duclau's publication, which you can find by scanning QR code. This is quite simple checklist, which was used for nurses in the ICU. But when this checklist was introduced, they realized that it not only decreased the ventilator-associated pneumonia rate, but also reintubation rate, ICU-free days, ventilator-free days, and central venous catheter-free days. You can see in the red box, this is the time when this checklist, just simple checklist, was introduced. Of course, we use checklist safe surgery from the WHO, and this year we have conducted the study in war-affected low resource settings for using this checklist, and really we have the data that 30-day postoperative mortality, reoperation rate, surgical infection rate, and any complication rate were significantly lower in group with this simple WHO checklist. Another point how we could improve safety is using cognitive aids for critical incidents management. Because this incidents happens and sometimes personnel have no idea or have no plan how to manage it. And in our practice, we use this Stanford program or algorithms of actions in emergency situations. They were written for anesthesiology, but also for ICU. They could be used. And this year we have just published a systematic review of 13 randomized controlled trials, which assess the incidence of missed steps, and it was a measure of competence of care. And of course, it showed that cognitive aid was really effective to help improve this competence of care. Cognitive aids were associated with decrease in the rate of missed steps from 43 to 11%. So that's really significant. And other idea how to improve safety is, of course, to provide training. In our ICU, we provide this training for emergencies with debriefing in the team of anesthesiologists, obstetricians, surgeons. This is the video of one of these training. And this is the small list of emergencies which we could train, and also communication training. And we show this year we have our publication as it is on review now to BMC anesthesiology, and it showed that difficult airway training for anesthesiologists really is very effective. and decrease the deviation from the dust protocol, both for can ventilate, cannot intubate, and can ventilate, can't ventilate, can't intubate scenarios. And it's improve also the numbers of successful surgical airways, and help doctors not to forget to call for help, and etc., etc. And regarding education, of course, we need to train not only anesthesiologists and intensivists, but also those who are residents, who are in residency. Now in Ukraine, we have new competence-based 3-year residency. Of course, we plan to make it more longer, but now it's 3 years, and we decrease the number of lections and increase number of interactive seminars, workshops, simulation trainings, because it really works better. And our residents, they show that these techniques are better, and they made better doctors, which are safer doctors for our patients. And of course, we use workplace-based assessment when we assess the knowledge, but the whole complex of intensivist, how he care about patients, how he communicate, how he manage critical incidents, and so on, so on. And of course, technical innovations. With these new devices, which we have now in our ICU and ORs, when we could do on this machine, for example, we could perform ultrasound for jugular vein catheterization, or for fast or to perform intraoperative echo. So it's really very, very easy and good to work in our ICUs and OR with these new technical innovations. But also, as you know, we have war in Ukraine now, and even our colleagues on the front line, they can use technologies now, and they use it. We have portable ultrasound, we have these monitors which help provide safety even in this extremal situation. And telemedicine. In Ukraine, we have a lot now, but I know there is the studies when, for example, anesthesiologists from Australia help anesthesiologists from USA to monitor the patient during night, because they have day in the same time. So this is just a good idea, and our anesthesiologists use help of intensivists from all over the world to care the most difficult patients. And how disaster and war influence patient safety? Of course, we have no randomized controlled trial about that, but you can imagine that it damage is very significantly, because near 8 million people leave the country. We have more than 1,000 healthcare institutions damaged, and electric infrastructure destroyed, and unfortunately near 40,000 of civilians were killed, and near 500,000 combatants also were killed or wounded in this war by now, but it's not finished yet, you know. And during these 2 years, we have more than 20,000 missile attacks, and most of them were on civilian goals. That's why, of course, disasters influence patient safety, and it make it quite more difficult. It's our ICU, pediatric ICU in the underground. And of course, your workspace could be just destroyed. Main challenges in safety during the wartime is, first of all, your safety, it's your flexibility in the workplace, It's your personnel could be moved abroad or to military forces, your new competencies to get, and you need to provide care with many minimal resources. And we have, of course, increased number of trauma patients and patients with delayed medical care. If we're speaking about ICU, first of all, when this war or disaster start, you need to organize some underground shelters with warm clothes, warm systems, alternative electricity sources, because as you know, Russians try to leave Ukraine without electricity, water reserve, medication reserve, and long-term food storage. And this is our ICUs during war, how they manage it. We have organized additional ICU rooms underground on the first floor, which was provided with additional oxygen supplies and protected windows if they have ones. We prepare hospitals for the wartime with education, with re-education in March in ITLS, and ILS, pulse techniques, casualty triage, and so on, and increased number of surgery rooms for trauma resuscitation. And this is how sometimes we need to just mark our patients because the lack of personnel and papers. And of course, difficult areas could happen very often when you face with trauma, and also massive transfusion protocols. We have ones, and sometimes we need to use it. We prepared to be flexible. Our doctors were re-specialized to other specialists. For example, obstetricians become just general surgeons. Pediatricians treat adults. This our Okhmadit, the largest Ukrainian children hospital, which also manage adults during war. And as a university, of course, we got new teaching opportunities. We start to teach tactical combat care and different protocols for triage, for ATLS, and some combination of these trainings. The last but not least thing about safety, which I want to just remember and want you to remember, is incidents reporting. The last year we have organized the national study on critical incidents during anesthesia, reporting and analysis, and find that they happen pretty often, and the most oftenly it associated with airways, with hemodynamic, but also such rare incidents as malignant hyperthermia, anaphylactic shock also appear in our hospitals. And if you will go to read this article, you will find even more information about it. So we believe that incidents should be a lesson for us to, first of all, we need to report incident, and then try to search for reasons, analyze the system, made action plan, and warning of future incidents. But to make risk visible, it's the main reason. And to make this, we need to report these incidents on the national and local level. And after that, of course, we need to do something with that. And this is just the ideas how it could be management. Of course, you need to know about something, then to study it, to do some plan, and to do it plan, and to analyze if it helps. So our home message is to make To make your ICU more safe for the patient, you need to create this culture of patient safety. And this is the video just uh, to share with you how we try to teach our doctors of this patient safety. The video demonstrates how safe anesthesia should be provided. It's in Ukrainian, but still, I think you will understand. This is the 10 components of Helsinki Declaration in safety in anesthesiology. And active involvement of personnel in the promotion of safety principles is crucial. Teamwork, open communication at all levels, checklists and cognitive aids. And here on the video, you can see that our anesthesiologists are checking equipment by the checklist, and after that, they check another equipment, anesthetic station, and they had the syringes market, and so on, so on. And after that, they provide monitoring, which is also very important. They use this algorithm for critical incidents when they occur during anesthesia, call for help, and after all, they report this incident and analyze it in the safe way to find the reason and to find how to change it. So teamwork is one of the key, checklist and cognitive aids, technologies, and training and education, and of course, reporting and learning from mistakes. I thank you for your attention. I'm looking forward to war in Ukraine to end with our victory very soon. And I believe that together we will improve our patients' safety. Thank you one more time.